The broadcast is now starting. All attendees are in listen-only mode.
Hello all, the AANMC webinar, Gastroesophageal Reflux, Underlying Causes and Related Cures will start approximately in 1 minute. All right. Hello, everyone, and welcome to Gastroesophageal Reflux, Underlying Causes and Related Cures. We are very pleased to have you with us today. Before we begin, please make sure that your control panel is expanded. There should be a box like the one shown in the upper right-hand corner of your screen. If you do not see the box, look for a double arrow. Click these arrows and your box will expand. Second, make sure that you can see my desktop, which currently shows the control panel image. This is the window you will use to view today's presentation. During the webinar, there will be opportunities to ask questions. Please note all attendees are muted, so type your questions into the box indicated here. All questions will be addressed during the question and answer period after the presentation has concluded. We will answer as many questions as we can in the time available. If you have any technical problems during the webinar, you can communicate with me using this question box. I will try to help you resolve any issues that come up. There will be a short pause between myself and Dr. Sandberg-Lewis as the GoToWebinar technology takes a few seconds to shift between presenters. Please be patient during these transitions. This webinar is scheduled to last approximately 1 hour. If we run out of time and you still have questions, we will continue on for another 15 minutes. And now let me introduce you to our presenter, Dr. Sandberg-Lewis. Dr. Sandberg-Lewis is a practitioner of naturopathic gastroenterology. He is professor at the National College of Natural Medicine in Portland, Oregon, where he engages in patient care and lectures and related topics. He is a frequent presenter at educational seminars around the U.S. and Canada. He has authored or co-authored a series of award-winning articles on hiatal hernia syndrome and intestinal bacterial overgrowth. He was listed among Portland, Oregon's top docs in the January 2014 edition of Portland Monthly magazine. As co-founder of SIBO Center for Digestive Health at NCNM, Dr. Sandberg-Lewis often treats patients whose health conditions have defied diagnosis despite exhaustive medical testing. Restoring ideal digestive function and normalizing the gut microflora have earned the center a reputation for success in helping many who previously suffered digestive diseases without hope of cure. His area of special interest within gastroenterology include inflammatory bowel disease, chronic unrelenting nausea and abdominal pain, GERD, reflux esophagus, and gastroparesis and hiatal hernia, and irritable bowel syndrome and other functional GI disorders, small intestine bacterial overgrowth, and esophageal motility disorders. And now I would like to turn the presentation over to Dr. Sandberg-Lewis.
Thank you. Sorry I gave you so many words that were hard to, but those are the things that I tend to do. Oh. So I'm happy to be talking to you today about reflux, and I am going to just look at my screen here. Should I click on show my screen key?
Yep.
Okay. So my background, went to Rutgers College in New Jersey for undergraduate, and also Newman University in the great state of Kansas, and graduate of the National College of Natural Medicine, 1978, and member of the Oregon Association of Naturopathic Physicians and the Homeopathic Academy of Naturopathic Physicians. And I thought I added it, but didn't. There's a new Gastroenterology Association of Naturopathic Physicians that I'm vice president of, and getting that going, which I'm very excited about. And I've been teaching and lecturing here at National College for full-time for the last 19 years. And as was said before, I'm one of the co-founders, staff physicians at the SIBO Center for Digestive Health here at our NCNM, beautiful NCNM clinic. They asked me why I was drawn to naturopathic medicine when I was getting involved so many years ago. And I was a psychology major at Rutgers College. Psychology seemed pretty exciting, but also kind of incomplete, as if the body was missing from psychology. And the philosophy of naturopathic medicine made total sense to me, to not separate the body from the mind. And wanted to do something with science, a practical application of it, and this seemed like the perfect thing to do. The reason that I decided to focus on the GI tract is because it's sort of the center of everything. I once spoke at grand rounds for the gastroenterology department up at our local medical school, hospital, biomedical school. And they were all kind of staring at me, looking kind of serious. And I said, so I just want to say that gastroenterology is the center of all health. And I put my hand up, high five, and everybody got really excited. And so that's what we think. We think that the GI tract is the center of everything: autoimmune conditions, mental and emotional health, and so many effects on every cell in the body. And I like it. I like it a lot. Pretty passionate about it. Wanted me to talk about what my routine's like. I'm always writing either articles or doctors' journals or lay publications as well. And then I'm also writing gradually, not super fast, but I am gradually rewriting my textbook on functional gastroenterology for a second edition. I see patients 20 hours a week, and that's direct patient care. There's a whole lot of other hours involved not seeing the patients in order to take care of them. I supervise naturopathic student doctors at the clinic for 16 of those hours. I have what's called a GI mentor, actually 2 GI mentor rotations per week, where students choose to do extra studies in gastroenterology and spend a full year working with me, really tough cases of gastrointestinal problems. And these are some of the seminars I've spoken at recently and where I'll be speaking the rest of this year. What I do for fun is my wife and I walk a lot through our neighborhood, and I perform with my band, Mickey Pickers, several times a month, which is almost as much fun as lecturing. Or I should say lecturing is almost as fun as playing. A few words about the SIBO Center. Put it together in 2012. We do lab testing for bacterial overgrowth, which is the #1 cause of irritable bowel syndrome and a number of other related problems. We treat patients, and we educate doctors and patients about this condition, research on this condition. Part of the NCNM clinic here in Portland, Oregon. We do use conventional prescription medicines as well as natural therapies, and listed here the natural therapies, herbal antibiotics and probiotics. Heavy emphasis on diet. 4 different diets that we conditions. Physical medicine, body work, emotional clearing work, and hydrotherapy. And these are some of the common antibiotic prescriptions and prokinetic prescriptions that we might use for a lot of our patients. This is what the clinic looks like. Flowers are blooming, and this is our group. Saunders is actually in her last year of naturopathic school, and she is our research coordinator. And the other 3 are the other doctors here at our center. So to talk about heartburn and reflux, reflux is a common term used to talk about gastroesophageal reflux. There's actually reflux in other parts of the GI tract, but most don't know much about them. We won't talk about those today. We'll focus on gastroesophageal reflux. And this is when stomach juices go in the wrong direction. Instead of just going down into the duodenum and the small intestine, they go back up into the esophagus. And it can cause symptoms of different types. Most common is a burning sensation. And interestingly enough, over 40% of adults have what's called a sliding hiatal hernia, which is a common and treatable cause of reflux. That's 40% of adults of all ages. If you look at people over age 70, it approaches 60% of adults. We'll come back to that. Most physicians diagnose reflux just based on the patient saying, I have burning pain just under my breastbone, rather than actually definitively testing for it. And then the standard treatment that biomedicine doctors use is a purple pill or proton pump inhibitor, which suppresses the parietal cell in the stomach from producing. These are some of the common prescription proton pump inhibitors. Lots of different names. And the only one that's really different than omeprazole, which was the first one that came out, is Zegerid, which is a combination of the proton pump inhibitor plus bicarbonate of soda to neutralize the acid if they're trying to get a rapid effect before the other drug takes its full effect. Movement of food through the esophagus. This is a little piece of food here. Normally moves through upper esophageal sphincter, which is a little increased area of tone in the muscles, upper esophagus, and then comes down to the lower esophageal sphincter as peristalsis moves it down. That opens up and allows the food to move through into the stomach. The lower esophageal sphincter is the site of dysfunction for many people that have reflux, because the job of the lower esophageal sphincter normally is to keep stomach contents from moving up into the esophagus. The job of the upper esophageal sphincter is to prevent air from getting into the stomach. Some people have trouble with that too, but that's for a different day. So the lower esophageal sphincter looks like this. This is esophagus up here that looks like a sheet or a curtain, and then this area that looks more wormy is the stomach below there. And there are layers of muscle that are longitudinal or circular, 2 different layers. And you can see the muscle gets kind of thicker here, and that's the lower esophageal sphincter, this part here. And this picture they've cut through so you can just see the cross-section of the muscle. Also, you'll notice the diaphragm is on either side, and there's an opening in the diaphragm called the hiatus. That's where the stomach meets up with the esophagus. But the diaphragm is a muscle as well, and it's a very actually an important part of the lower esophageal sphincter. It gives extra, sort of an extra collar of effect to the esophagus, muscles in the esophagus. So it's really part of the lower esophageal sphincter. If you look at the diaphragm from below, we were looking from the person's feet up toward their head. The diaphragm, here's the hiatus, or the opening of the diaphragm that allows the esophagus to pierce through and meet up with the stomach, which would be below the diaphragm here. And the diaphragm has a right crus and a left crus. And crus means leg. It's actually just a fold of muscle that kind of wraps around, and that's the part that really helps make the lower esophageal sphincter stronger to prevent heartburn. Heartburn here is a symptom, burning sensation in the chest, and that could be due to acid coming up into the esophagus. It could actually be due to neutral fluids moving up into the esophagus. For instance, if a person's taking a proton pump inhibitor, the acid is suppressed. So now any fluid coming up from the stomach into the esophagus is actually close to neutral. It's not acidic. But that can still cause heartburn. So some people take proton pump inhibitors, but they still have heartburn and other symptoms in the esophagus. And then there's something called functional heartburn, where there's really no reflux. There's no stomach contents are coming up into the esophagus, but the person still has the symptoms of heartburn. You might ask, how can there be burning if there really isn't strong acid? How can there be burning if there's neutral reflux? Well, the simplest way to describe that is what's called dilated intercellular spaces. This is a electron micrograph of esophageal tissue, and it's showing these dilated spaces between the cells. These whiter areas, lighter areas are the spaces between the cells, and these are dilated. They're wider than they should be. And those dilated intercellular spaces are present in almost everyone who has a reflux of these different types. And it could be that these spaces allow penetration of irritating fluids that will irritate the nerves. So we think that you don't actually have to have any acid in order to have heartburn or reflux symptoms. Here's an example. If someone did have acid reflux, proton pump inhibitors suppress the acid. Now you have neutral fluid refluxing up into the esophagus, but because of these dilated spaces, they still have heartburn. One of the more serious things that can happen with long-term reflux is that the normal esophagus with chronic reflux and inflammation can develop changes in the cells called Barrett's esophagus, which is when the cells change to a different cell type. The body's best attempt to deal with that chronic irritation and inflammation. And unfortunately, if things continue to move in this direction, dysplasia can occur, which is a precancerous change. And it can be low grade or high grade. As things get worse, it gets high grade. And that is an immediate precursor to cancer of the esophagus. So cancer of the esophagus can be due to chronic inflammation from reflux. So it's a really important thing to take care of. The incidence of cancer of the esophagus is not great. It's not of the order of magnitude of, say, colon cancer, which is the most common cancer in women, but it is still a risk factor, and we'd like to. Of course, breast cancer and prostate cancer are the number one cancers. Then comes lung cancer. Then comes colon cancer. If I said colon cancer was the number one cancer, it's It's in the top 3. So heartburn, this diagram shows a number of different common things that can cause heartburn and reflux. I mentioned hiatal hernia, and we'll spend most of our time on that. These things on the side are just different tests that can be done to diagnose these conditions. Food sensitivities, food allergies, lactose intolerance, gluten intolerance, all these things can also cause heartburn and reflux. Overgrowth of bacteria in the small bowel, what we focus our SIBO center here on, that definitely cause reflux and heartburn. And as I said, not enough acid, even just normal levels of acid, or too much acid. All of those things can cause heartburn. We like to assess that and decide which one it is. If you suspected more serious disease, like those changes that are precancerous, upper endoscopy exam could be referred out, and that could be done to make sure that none of those Barrett's esophagus or this syndromes are present. And then also the pancreas is really important in normal digestion, and something called chymotrypsin is a test, or elastase. Both of those can be measured in the stool. If those are low, then there's decreased production of pancreatic enzymes. We call that pancreatic insufficiency, and that is also a major cause of heartburn and reflux symptoms. So those are all things that can do it. It's not just too much acid, like some people will lead you to believe. The simplest heartburn treatment is change diet and habits. And this, we recommend this to everybody to consider factors, and we call it cut out the crap. And it came from Dr. Sherry Rogers, who's an MD who wrote a book called No More Heartburn. The first chapter talks about it. And so C stands for coffee, cigarettes, and chocolate. The use of these things, especially in excess, can affect the tone of the lower esophageal sphincter, the amount of acid being produced. Not every factor here is important for every patient, but this is kind of our big list of cut out the crap that we want patients to look at and assess what they're doing with their habits. Refined carbohydrates, white flour, white sugar, all those things tend to increase the risk of reflux. Eating too rapidly, not chewing thoroughly, as do some drugs. Drugs can relax smooth muscle, and some of the drugs, for instance, that might be used for treating high blood pressure, they relax muscle structures, and certainly drugs that are used to treat spasms in the muscles, those can also relax the lower esophageal sphincter muscle and cause reflux. A is for acid. Some people react to acid foods, tomatoes, things like that. Alcohol is a factor that can really trigger reflux, as is any food that a person is allergic to. And P stands for soda pop. Peppermint. Peppermint is a natural smooth muscle relaxant, so it can aggravate reflux for some people. I added this one, packing in food at bedtime, so it's best to food at least 3 hours, at least 2 hours, or lying down to go to bed. That can be an important thing. And progesterone in women can also relax lower esophageal sphincter too much, so sometimes taking progesterone medications or producing too much progesterone in the body can be a problem. So again, here's a list of medications that can relax the digestive muscles and cause reflux. And menthol's in there, that's the peppermint, strong peppermint, such as Altoids. Yeah. The treatment for reflux Herbal and nutritional therapy, these are some common substances that are used. I'll just pull out one of them to talk about for a second. DGL, or deglycerized licorice root, is a common one that people use. And glycerized so it doesn't have the herbal constituents that stimulate increase in blood pressure or stimulate the adrenal stress hormones. This works as a demulcent or a soothing agent in the esophagus and the stomach. Zinc carnosine is a form of zinc that is very specific for the GI tract to help heal irritated membranes and gut syndrome as well. Dr. Davis Lamson, who's a naturopathic doctor in Washington State, came up with a nice protocol for first two steps of treating reflux. One is if the patient is not making enough pancreatic enzymes or enough stomach acid, he will give replacement enzymes for this, acid and enzymes. There's a test called the Heidelberg pH test, and that's how we determine if the person is making too little or too much acid. If that alone doesn't take care of the reflux, then a second stage is to increase the tone of the lower esophageal sphincter to make that muscle more effective. And lecithin and an extract from a Chinese herb called huperzine A can be used to help tone that muscle, and I've seen that work really well. So quickly, to talk about hiatal hernia and hiatal hernia syndrome. Hiatal hernia, here's the diaphragm, here's the stomach, hiatus of the diaphragm with the lower esophageal sphincter, and then the esophagus. In hiatal hernia, the upper portion of a small amount of the upper portion of the stomach protrudes above the diaphragm into the chest. This can raise the lower esophageal sphincter so it's no longer at the level of the diaphragm and it loses some of its tone, causing reflux. These are some of the common symptoms of hiatal hernia, and I'd just like to point out that besides pressure and pain in the chest and heartburn and other symptoms, it can also cause anxiety and a tickling, non-productive cough, meaning they're not coughing up any mucus, but tickling, irritating cough, which can go on for months or years until this is corrected. Little spot right here to the left of the xiphoid bone in the chest is the point that we use to see if the patient has this syndrome. It'll be very tender if they do. That's how it looks on skin. We have if we find that this syndrome is occurring or the person has an endoscopy or x-ray that shows that they have a hiatal hernia, we'll use this treatment where we a deep massage technique to reposition the stomach and bring it down out of the chest back into the abdomen. It takes about 5 minutes to do this. Some chiropractors do a different version of this where they do a similar looking contact on the abdomen, but they'll pull down pretty violently. It's called a thrust. And I don't use a thrust. I use more of a gentle visceral correction, which I've used both, and I find this works just as well or perhaps better. It's a lot easier on the patient. We also work with the diet, getting the refined carbohydrates out of there and simplifying the diet, having them also make sure that they don't hold their breath when they exert, because that tends to increase the pressure in the abdomen and can push the stomach back up to the chest. And I mentioned either there's corrections in the front of the body, but we'll also do massage along the spine or spinal manipulation, the base of the skull, the occiput, of the back. at the thoracic 10 and 11. These areas have a lot to do with the function of the lower esophageal sphincter. To show there's where the occiput would be, and there's T10 and 11. We also have patients take home an information sheet that reminds them to do an exercise called the heel drops. Drink 12 to 6 ounces of water in the morning when they get up, and they stand on their ball of their feet or their tiptoes and then drop onto their heels 11 times. This helps pull the stomach down each morning for 2 weeks after the correction that we did in the office. It helps it hold better. And if they're not doing any abdominal core strengthening, we like to have them do that along with proper breathing to increase the tone of the muscles there. The standard treatment, if the proton pump inhibitors don't work for a hiatal hernia, is to do what's called a Nissen gastric fundoplication surgery. That's when fundus or upper portion of the stomach is pulled around behind the esophagus and sewn to itself in the front here, like a little turtleneck for the stomach to increase the function of the lower esophageal sphincter. Every once in a while we have a patient that needs that because nothing else works, but it's pretty rare that we have a patient get this. And I wanted to finish with a case study. Let me get this. On the other side. There we go. So this is a patient that way back in 2008 had clutching, squeezing chest pain early in the morning. Lasted about 15 minutes. It was really intense. She said she could barely speak because it hurt so much. She couldn't get up and walk. She just felt like she had to stay there and clench her chest as if she was having a heart attack. And so she was checked for that possibility. Not getting any suggestions?
What's going on?
It doesn't seem to be advancing. It was before, but...
Are you trying to show a video or go to the next slide?
Just go to the next slide. Oh, there it went. I guess it was...
Okay.
So she saw a Chinese medicine doctor because she was a student at the Chinese medicine college, and was given some herbs which helped decrease the pain somewhat after a few days, but it didn't go away completely. Still felt like there was a fist squeezing around her heart, she said. And she went up to the medical school and had work up there. They said it was not a heart problem. So this was continuing, and it was really affecting her energy and her functioning, and so she dropped out of some classes to the bare minimum and was exhausted all the time and really concerned why she was having this chest pain. And she took one of the lab courses that I give here where we show the treatment of hiatal hernia syndrome, and had the visceral manipulation that was practicing how to do that. And I guess the student didn't quite get it all the way corrected, but about 6 weeks later she made an appointment and came in and saw me at the clinic. and we did a correction. And she said when she sat up at the table, she didn't have that pain anymore. And at the time she wrote this for me, it had been 7 months, and she hadn't had the pain except once she had a little return of a minor symptom. Now she's a graduate naturopathic doctor and acupuncturist for the last, I think she graduated in 2009, so she's been a doctor for about 6 years now, and still has not had any problem with this. Tips for practice: find something you love. If it's everything, be a general practitioner. If it's limited, let people know what you love doing. Have a good time with it, and be a lifelong learner. And get the word out by studying a lot, writing to other people, and teaching in other ways. Things I'm looking forward to. Presently, at our college, we have a required gastroenterology course. We have 3 gastroenterology electives. We have full-year rotations where students work in the clinic with complicated cases with me. And we have the center, and in the future I'd like to add a 2-year residency for gastroenterology at NCNM and funnel those residents into positions in biomedicine gastroenterology specialty practices when they finish their residency. Looks like I didn't insert my contact info.
Well, thank you very much. And I now want to go over just a couple of events that we have. And then once we go through this, we will answer all the questions you guys have. We have a couple events coming up. We want to invite you to our March webinar. And we also have the AANMC National Convention coming up February 27th through 28th, as well as some regional events where you can attend and meet with all the deans, and you can see all those listed below. And to find more information on these events, you can go to our website, aanmc.org/events/forms_webinars. So if you get a chance, please check that out. And I will now open the floor up for questions. All right, so our first question will be, I may be pronouncing this word wrong, but what is the Cedars-Sinai diet?
Am I still coming in well? Can
Yep.
you hear me?
Yep, we can hear you just fine.
The Cedars-Sinai diet is a low fermentation diet that was created by Dr. Mark Pimentel down at Cedars-Sinai Medical Center in LA, California. And what he wanted to do with that diet was create a diet that had fewer fermentable carbohydrates, which are normally foods for intestinal flora. And he wanted to create a diet that didn't feed those bacteria as much because he wanted a diet that would help prevent overgrowth of bacteria in the small bowel, and especially after he had treated patients for overgrowth, keep it from coming back. And so the Cedars-Sinai diet it's actually the most, it's the broadest diet that we use for patients that don't want a more restricted type of diet. And it works quite well for a lot of people for that purpose of preventing recurrence of SIBO. Do you want any more details on that?
No, I think that should be good. We'll go to our next question. Okay, as a health coach, I can support clients who want to get off their PPIs even when their doctors are unaware of harmful effects of long-term use. How can I support clients? Yeah.
How can you support clients in the weaning off period?
Yes.
Okay. So first of all, what I like to say is if you look at that that chart that I showed before that showed the different common causes of reflux, the first thing I want to do is correct any of those causes that I can. So if it's pancreatic insufficiency, we're going to get those pancreatic enzymes in there. If they don't make enough stomach acid and that's what's causing it, if they're taking a proton pump inhibitor, you know that that's going on because that's the purpose of the medicine. So that gets a little more complicated. But if they have bacterial overgrowth, that should be treated first. If they have a hiatal hernia or hiatal hernia syndrome, I like to treat that. And then once those underlying causes are treated, then I'll work with them to gradually wean off the proton pump inhibitor. And the way I usually do that is, say they're on a twice-a-day dose, we'll cut down to once a day, and we'll see if they're doing fine, if they're not having symptoms. Then if they were on a high potency, we'll go to the lowest potency of that drug, and we'll do that once a day. And then if they're doing fine after a week or two of that, we'll do an every other day dosage. And if they're doing fine with that, we'll go to every third day. If they're still doing fine, not having symptoms, they can then discontinue it altogether and see how they're doing. If they're having some problems, there are some medications that are over the counter, such as cimetidine, which is the oldest drug for this purpose, also called Tagamet, brand name. And cimetidine, it doesn't suppress acid as much as a proton pump inhibitor, so sometimes we'll switch a patient over to that or one of the other what are called H2 receptor antagonists, and virtually all of those are over the counter, so people can just get them at the supermarket or drugstore, and they'll take that once a day for a while. Some patients have been on proton pump inhibitors for so long, sometimes 10, 15 years, that we'll do this very gradually and in that kind of a manner.
Okay, thank you. If a sliding hiatal hernia is in 40% of the population, should it be considered normal?
Yeah, in a way, you could think of it as physiologically normal. We didn't get into all the causes of it, but one of the most common reasons that somebody might have that is because of vomiting. So if a woman had extreme nausea and vomiting in pregnancy and was vomiting daily, or they had a severe gastroenteritis and or had extreme retching or vomiting for a period of days, that can cause the stomach to move up into the chest. And so in a way, it's something the stomach can do. It's part of normal retching and vomiting for the stomach to partially move into the chest and be thrust up into that. The question is, should it stay there? And so a sliding hiatal hernia that just falls back down, stomach falls back down into the abdomen after the vomiting or retching, that's not going to cause any symptoms, but it's when it tends to move up and stay up into the chest that it causes symptoms.
Okay, thank you. What is it about the dilated spaces that cause heartburn?
Oh, yeah. So the dilated intercellular spaces, it's thought, there are theories, there's no right answer, but one of the main theories is that those dilated spaces allow for the secretions that are coming up from the stomach to irritate the nerves, because it allows the irritating effect of the gastric secretions to get deeper into the tissues and irritate the nerves. And that's one of the main theories as to how that works.
Okay, can you reverse Barrett's?
Say that again? Oh, reverse Barrett's?
Yeah.
Yeah, I have seen Barrett's esophagus go away when you, number one, when you treat the reflux effectively, and when you, interestingly enough, Helicobacter pylori overgrowth actually reduces the risk of getting Barrett's esophagus in the first place. So flora is very important. People hear a lot of bad things about H. pylori, but it actually has some protective effects too. And the other things that I do to help heal it, which are based on research into Barrett's esophagus and its cure. One is we increase fruits, fresh fruits and vegetables. Sometimes we will use a berry extract to get more of those anthocyanidins that seem to be so important for healing the tissue. We also give selenium if they're deficient in selenium. That has been found to help prevent Barrett's esophagus from progressing. We also use curcumin, which is turmeric, as a healing herb for those tissues. And I have seen that approach work quite well. Again, you have to treat the underlying cause, whether it's hiatal hernia or pancreatic problem or some other problem. But with those things in place, I have seen Barrett's normalize when they have retesting, which they normally will have yearly to monitor the tissue.
Okay, could you please mention that Chinese herb that you talked about in your presentation? What was it?
Yeah, so huperzine A is an extract from the Chinese herb Huperzia serrata. And Huperzia is it's an herb that contains some substances that specifically they're called excuse me a minute here. Huperzia, it contains huperzine A, and huperzine A is an extract of the component in Huperzia serrata that actually makes the neurotransmitter acetylcholine act more effectively to tone the lower esophageal sphincter. Acetylcholine is the major neurotransmitter that turns on all the vagal nerve function, the parasympathetic function that controls the tone of all the sphincters in the GI tract. And so we use that herb for that purpose, to give it more tone.
Okay, thank you. How does a probiotic affect GERD?
Well, I mentioned that overgrowth of bacteria in the small bowel can cause GERD. And the mechanism there is probably the fact that when certain organisms make methane gas, which 20% of people have an organism that can do that in the small bowel, methane gas tends to cause more sort of a reversed flow of material through the GI tract. And those people can get very constipated, and they can have reflux because of things moving toward the mouth instead of toward the anus. And probiotics have been shown to influence that, and several studies have shown that different probiotics can rise the levels. My phone's ringing. Can normalize the levels of bacteria in the small bowel. So probiotics probably work that way.
Okay, thank you. Since you don't want to use a PPI to decrease acid, what do you suggest to patients in the meantime if they are experiencing great pain when having reflux?
Well, I'm not saying you should never use a proton pump inhibitor. Sometimes we do use that until we can treat the cause, and then we slowly wean, as we talked about before. You can also use the over-the-counter H2 receptor antagonists, like we mentioned before, Tagamet or cimetidine, and there's a whole group of those. And you can also do the things that I listed on that slide, things like aloe vera juice, slippery elm gruel, DGL, D-limonene, gamma oryzanol. There are a number of natural herbal as well as nutritional substances that can either relieve the symptoms as a demulcent, protective kind of effect, or treat the underlying cause. And so we usually use a combination of those kinds of treatments. And then, of course, if it's due to a hiatal hernia or the hiatal hernia syndrome, correcting that is instant relief.
Okay. If a patient is experiencing mild reflux but no pain, is it too early to begin testing?
No, pressure or even just anxiety. I test all my patients with anxiety or chronic non-productive cough. I check them all for this condition. So, the simplest thing you can do to rule out that one possibility, might not have imaging for hiatal hernia if the symptoms were really minor, but you could certainly check that reflex point to see if there's a functional cause, and that's a simple thing to do. Checking for pancreatic enzymes with stool testing is very non-invasive and is a great thing to do. Stomach acid testing with Heidelberg is a moderately invasive test, but with great information. There's also applied kinesiology testing that can sometimes give a good clue as to what's going on. There are a lot of things that could be done even if the symptoms are just beginning.
Okay. Do you have any suggestions or advice for an undergraduate in microbiology who want to get involved in working in a testing facility such as the SIBO Center?
Well, we don't have any openings here right now. We have 3 what are called breath tracker machines that do that testing for hydrogen and methane in the air, the exhaled air. And there are doctors' offices around the country that do this kind of testing, and I guess you could Google that in your area and see if there's someone that does SIBO testing. And there are national labs, several of them, that do more volume as well. So I'm not sure what you would do except to contact them.
Okay. Does everyone with hiatal hernia have symptoms? And if not, should it then be treated?
Yeah, it's kind of related to the question of if it's in 40% of the population, is it really a condition that needs treatment, or is it a disease, or is it abnormal? So yeah, I think if it's functional and it occasionally slides up and doesn't cause any symptoms because it goes right back down, I don't think there's any need to treat it. But certainly, if someone has symptoms, it's a pretty straightforward thing to treat if the body worker or the physician knows how to do that.
Okay.
And I have a whole chapter on that in my textbook. Forget which chapter it is, but explain that.
Okay. Do you believe that if you have type 1 diabetes, it could be a possible factor for your severe heartburn?
It can be. In diabetes type 1 or 2, there's a condition called autonomic neuropathy, and that's when the nerves that control parasympathetic and sympathetic function in the GI tract get affected, and they're not working as well as they should, and that can cause all kinds of changes in the gut. It tends to alter the hydrochloric acid production. It tends to affect motility or movement of food through the digestive tract, and it's actually a very strong risk factor for the development of bacterial overgrowth in the small bowel, which, as we said, those microorganisms can make gases such as methane, which can cause pretty severe reflux. So yeah, I find that a lot, and we always ask about that. We check for it if it hasn't been tested for when we're treating a patient with reflux or bacterial overgrowth.
Thank you. Are infants who have reflux more likely to get it as adults? And if so, will they be at higher risk for esophageal cancer?
That's a great question. It's always good to point out that babies can have reflux. Babies that didn't sleep well and cried a lot and brought their legs up to their chests and flailed around, they used to just call it colic. But we know that it can be intestinal, but it can also be reflux causing those same kinds of symptoms in babies. And if their reflux is due to a correctable condition such as hiatal hernia, then if that's not corrected and their reflux continues, they are at increased risk, like anybody else, to get Barrett's esophagus and other further complications of chronic reflux. So it's not a sure thing that they won't outgrow it, but if the cause is not treated, sure, they can have it as adults and they can be at risk to those kinds of complications.
Okay, thank you. How do you recommend patients go about finding a practitioner who does physical examinations for hiatal hernias?
I should get better about making a list on my website of all the students and doctors that I've taught to do this technique, people that really seem to do it well. I think what we'll do is first of all, if you go to the AANP website, which is naturopathic.org, you can go to Find a Practitioner, and you can look for doctors in your area and read their little bio. And they usually say if they're good at this technique, they'll mention it in their bio or on their website. So that's one way to do it. I'm also thinking with our new Gastroenterology Association of Naturopathic Physicians, maybe we'll have a little place on our site that talks about different techniques and which doctors are well versed in them. But we're just starting that website. You can take a look at it if you like, but we'll put more on it as time goes by.
Okay. How do you manage a patient that has been on PPI for more than 7 years, and how do you avoid rebounding effect?
Yeah, thanks for bringing up the rebound effect. So the reason that we want to gradually wean patients, decrease the dose gradually, decrease the number of times a day, maybe use a different form of a H2 receptor antagonist. And for some of these patients, it's a 6-month process. If they've been on this for a long time, it just depends. The reason that we want to do it slowly is that rebound is a very common phenomenon when you've been suppressing the proton pump in the parietal cell and it can't make acid for years. When that's going on, there's a neurohormone, a GI hormone that's made called gastrin. It's a stimulator for stimulating gastric acid production. And when a person's taking those proton pump inhibitors, their gastrin levels in their blood are super high. That's called hypergastrinemia. When you stop taking a proton pump inhibitor, your gastrin levels are still really high. And all of a sudden, if you're not taking the proton pump inhibitor, the parietal cells in the stomach can now make acid. They can now respond to all that gastrin hormone in the blood that's trying to trigger them to make acid, and suddenly they can be making way more acid than they've ever made before they took that drug. And so that's called rebound because they'll get a lot of acid symptoms from that excessive acid. So that's why we do it really gradually, as I explained before.
Okay, thank you. And this will be our last question of the day. What are some lifestyle changes that are recommended? Can posture cause a gastroesophageal symptom to worsen?
Thanks for bringing that up. This is a great group of questions, by the way. Really good. One of the things that I look at in my patients is I look at the arches of their feet. If they have a tendency toward reflux, and it might seem way off, the wrong side of the body to someone, but what I find is that the dome-like structure that would occur if you were to put your feet together and if you had good arches, there'd be a little dome there. If that dome is gone and it's flattened out, that can flatten out all the other domes in the body, and one of those other domes is the dome of the respiratory diaphragm. So sometimes we find that someone who has flat feet, it's actually affecting their diaphragm and having it sort of cave in toward the stomach, and then you get more pressure from the stomach against the diaphragm. And so that might be a real important thing to do, is to deal with their flat feet. And when people have flat feet, it also tends to rotate their pelvis, internally rotate their knees, and can also cause compensations in their spine all the way up to the occiput, the base of the skull. So that's why we work on people's posture, we work on their arches and the diaphragms in the body, and yeah, definitely crouching, being bent over all the time can put more pressure at the costosternal angle there at the ribs in the front, and it can aggravate this condition.
Okay, thank you. Well, we are out of time, and on behalf of AANMC, I would like to thank Dr. Sandberg-Lewis for his time. I'd also like to thank each of you for attending this presentation. The webinar has been recorded and will be archived and available for listening on our website, aanmc.org, sometime next week. So we'd like to thank you for attending, and this concludes our webinar.